everyone, welcome to OsteoBites. Happy Thursday. We'll give a few seconds for everyone to get settled and join our virtual room. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Rachel Offenbacher from Children's Hospital Montefiore. And Dr. Offenbacher will discuss her work on targeting urea cycle dysfunction to prevent and treat osteosarcoma metastasis. Thank you so much, Dr. Offenbacher, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelist, Walker, for joining us. A little bit more about our guest today. Rachel Offenbacher is an attending physician at Children's Montefiore and assistant professor of pediatric hematology, oncology, marrow, and blood cell transplantation at Montefiore Einstein. Since joining the Montefiore team, Dr. Offenbacher's clinical focus has been pediatric sarcomas. After obtaining her Bachelor of Science in Biomedical Science at the City College of New York in 2014, Dr. Offenbacher earned her Doctor of Medicine at the State College of New York Downstate in 2017. She completed a pediatric internship at Children's Hospital Montefiore in 2018, followed by her pediatric residency in 2020. Dr. Offenbacher remained at CHAM to pursue a pediatric hematology oncology fellowship, which she completed in 2023. Congrats. Dr. Offenbacher is on a physician-scientist track, working in a developmental biology lab, conducting translational bench research at Montefiore Einstein. And her research focuses on utilizing difluoromethylornithine, which from now on I'm going to refer to, for everyone's sake, refer to as DFMO, to prevent and treat metastatic osteosarcoma. She's seen impressive results in her in vitro and in vivo models and is working to initiate a clinical trial. She's simultaneously working on a project funded by the American Association of Cancer Research, targeting the tumor microenvironment of metastasis to treat metastatic Ewing sarcoma, which is demonstrating promising results. Dr. Offenbacher's work has been published in numerous peer-reviewed journals and presented nationally and internationally. And in 2020 and 2022, she won the Leo M. Davidoff Society Teaching Award. And in 2022, she won the Pediatric Research Day Oral Presentation Award from CHAM. Dr. Offenbacher is also a volunteer pediatric oncologist at Camp Simcha, a residential camp for children with cancer. I was just talking with Dr. Offenbacher. I'm going to be at AACR next week, and it reminded me that that's where we first met at your poster presentation on this very topic. And so it's taken a while just due to scheduling to have you on, but super excited and really looking forward to hearing your presentation today. Just a couple of announcements before we get started. Actually, really one major one is about our Factor conference in June 20th to 22nd. It's going to be in Cleveland this year, and registration is actually filling up really quickly this year. So we may sell out, so I definitely recommend registering to save a spot. Factor is unique in that it brings together everyone in our osteosarcoma community: clinicians, researchers, patients, caregivers, patient advocates, vendors, and industry. And if you're listening to this webinar right now, then you belong there. You will come to collaborate and you will leave re-energized and inspired. And here are some of our scientific panels that we're going to have this year. We will have some speakers on how AI will impact clinical practice and research, targeting metastasis drivers in osteosarcoma, overcoming drug resistance, key pathways in osteosarcoma treatment, local control, covering radiation therapy, interventional radiology, surgery, preclinical models, immunotherapy approaches, clinical trials, and backed by popular demand. And Walker will be on this panel, our patient panel. And we also have a fabulous lineup of classes. If this is really like a conference like no other, we have a wellness track. So we have things like yoga, sound bath, flower arranging. We have a crochet class being taught by one of our osteo warriors on our junior advisory board. So there's really something for everyone. And to kick it up a notch this year, our junior advisory board is also planning a prom after dinner on Friday evening. So if you missed your prom the first time around, this is your chance. So I'll put some more information in the chat about Factor and how to register. Walker, could you go ahead and introduce yourself?
Yeah, hi, my name's Walker, and I'm part of this year's Junior Advisory Board. And not to beat a dead horse, but definitely go to Factor. It's a ton of fun. It was a great time last year. That was my first one, and very excited for the crochet course. Didn't know we were gonna have that, but yeah, very excited. Other than that, though, really excited to hear what Dr. Offenbacher has to share with us today. So you can take it from there, Dr. Offenbacher.
Thank you. I'll go ahead and share my screen. Does that look good to you?
That looks perfect.
Okay, great. So thank you very much for that introduction. I'm going to be talking today about targeting urea cycle dysfunction to prevent and treat osteosarcoma, and I'll throw in a little bit of Ewing sarcoma metastasis. Pediatric sarcomas comprise approximately 3 to 4% of all childhood malignancies in patients 0 to 14 years of age. However, as patients age, they comprise about 6%, as we know this is primarily an adolescent and young adult cancer. Since the advent of chemotherapy, we've seen major improvements in all types of outcomes for patients with cancer. However, you can see on the right panel, both the dark green and light green, for patients with sarcomas, we have not seen any progress since the 1990s, despite various clinical trials, and we can see improvements in every other type of malignancy. Prognosis is highly dependent on localized versus metastatic disease. We know that for patients with Ewing sarcoma, independent of where the cancer is, whether it's within the bone or the soft tissue, these malignancies are completely dependent on whether there's metastatic presentation when the patient presents a diagnosis. And the same is true for osteosarcoma. Outcomes for patients with localized disease is favorable, but for patients with metastatic disease, it is far poorer. And ultimately, many targeted therapies are currently being studied, but developing targeted therapies focused on and measured by local tumor response fail to address the most pressing need for osteosarcoma and Ewing sarcoma patients, and that's the prevention and treatment of metastatic disease. The Loeb Lab in the Albert Einstein College of Medicine has a clinically relevant mouse model of spontaneous distant metastasis, which mimics the clinical course of pediatric sarcomas. We take a patient-derived xenograft, a small piece of a patient tumor, 1 millimeter, and implant it subcutaneously in the fat of a mouse. This tumor is allowed to grow. If it grows in the subcutaneous area, it can then be reimplanted subcutaneously, and the mouse can grow, and the tumor can grow to at least 2 centimeters, and the mouse will never develop metastasis. Independent of whether we take that tumor out and allow it to regrow, it will never, ever develop a metastatic lesion. However, if we then take a piece of that patient-derived xenograft and implant it in the pretibial space, which is the location of most osteosarcomas, and then we allow that tumor to grow, when the tumor reaches about 1 to 1.5 centimeters, we can amputate that limb, clipping off the femoral artery, nerve, and vein, and allowing the mouse to live on 3 legs. These mice can live a very fruitful life. They can continue to eat and drink. They can grow. They can mate. They can even bear children. And this model helps us because we know that when these tumors are amputated, the cells have already disseminated into the lungs and bone marrow, and can ultimately demonstrate distant metastasis, a model which is clearly what we see in our patients with osteosarcoma. We know that the microenvironment matters, and we know this from many previous studies, but in this particular model, when we were looking at the subcutaneous tumors in comparison to the orthotopic tumors that do metastasize, we found that there was a significant amount of arginase expression in the subcutaneous tumors where there was really no arginase expression at all in the orthotopic tumors. Well, what's special about arginase? Well, it's a key component of the urea cycle. It converts arginine to ornithine, releasing urea, and then ornithine is converted to polyamines by ornithine decarboxylase, the rate-limiting step in the urea cycle. What are polyamines? Well, they're low molecular mass positively charged macromolecules, and they've been implicated in many cellular processes. And most importantly for this talk, they've been implicated in metastasis. And there's 3 main types of polyamines: putrescine, spermidine, and spermine, which are important components. DFMO, or DL-alpha difluoromethylornithine, is an irreversible inhibitor of ornithine decarboxylase, that initial rate-limiting enzyme within the polyamine biosynthetic pathway. And it's now been FDA approved as maintenance therapy for patients with high-risk neuroblastoma to prevent relapse. And so we hypothesized that DFMO inhibits osteosarcoma and Ewing sarcoma metastasis from the inhibition of arginase, that enzyme responsible for polyamine production, as a result of the dysregulated urea cycle. And understanding the metabolic effects of DFMO would allow us to reveal synthetic lethal vulnerabilities that can be leveraged to prevent the metastasis and be readily translatable as maintenance therapy for our patients. So we started off looking at these cells in vitro, and for clarity, I've only shown one cell line here, but we've did all of these experiments in 6 cell lines from both Ewing sarcoma and osteosarcoma. And what we found was that there was a rate-limiting step in proliferation for all of our cells treated with DFMO. And we found that we were able to find IC50s for all 6 of our cell lines. However, when we looked at these cells under the microscope, it was very evident that although they were not proliferating, the cells were clearly not dying. And so we performed these same proliferation assays, but instead of treating the cells for 5 days, after 4 days, we washed out that drug and we allowed it to repermeate with healthy, fresh media, and the cells were able to regrow, as you can see in this panel below. And to formally understand what was happening and where the arrest was occurring, we did flow cytometry and cell cycle analysis and found that there was a G0, G1 arrest, and cells were really stuck in this phase in all of our cell lines. However, as I mentioned to you, we believe this is all due to polyamine depletion. And therefore, instead of just washing out the drug after 4 days, we instead washed out the drug after 4 days, but instead added back the drug, but in the presence of spermidine, that polyamine I mentioned a few slides back. And you can see in the dark colors here, those same cells were able to regrow, even being treated with drug, as long as there was spermidine added back. Spheroid assays are a model to help us understand stem cellness in vitro and can be very well utilized assays to test different drugs in vitro. We started off by treating various cell lines with and without DFMO. We plated very small amounts of cells in ultra-low attachment plates with particular media that allows for stimulant of spheroid formation. And you can see in panel A, if no drug is added, these spheroids are able to coalesce and form very, very actively. However, in the presence of drug, there are very, very small spheroids that can form. Taking all this into account and understanding that this drug was likely not causing apoptosis and causing true cell death, we thought, well, what if we treat these already formed spheroids with very high levels of DFMO? And so we went on to do that. You can see in the bottom panel, all of these spheroids were treated with various concentrations of DFMO, and you can see that there was no change whatsoever, independent of how high a dose we gave. We then went on to ask the same question, but instead of replacing the drug, we actually augmented the drug with spermidine and aminoguanidine, those polyamines I mentioned before. And so you can see in the panel C, this panel on the left, these were treated with drug alone. And you can see that there are cells that are really not active. They were not able to coalesce and form spheroids. However, if you add that same amount of drug, but not just the drug, allow it to have polyamine add back with spermidine immediately upon presentation, you can see that the spheroids can form quite well, demonstrating again that this drug is completely inactive in the presence of polyamines. We then went on to perform sarcosphere assays, another assay which is very similar to the spheroid formation and another way to look at stem cellness. And we plated these cells in sarcospheres in soft agar and allowed them to grow. And you can see in the control group all of these black various sarcoids that have grown and really permeated. However, independent of how much drug we added, we were unable to find any sarcosphere formation. We then went on to look at this model in vivo. And so we implanted small amounts of sarcoma cells subcutaneously into the mice. And we chose to implant 1,000 cells and immediately treat them with either 1% DFMO, 2% DFMO, or control, regular drinking water. And we found that in almost every mouse treated with regular drinking water, they grew a very large tumor within 8 weeks. The same was true with our mice treated with 1% DFMO. However, in our mice treated with 2% DFMO, we really did not see that same effect. There was really a dose-limiting toxicity that we were demonstrating. And so we went on to perform assays in vivo. like I mentioned before, we have a clinically relevant mouse model where we implant patient-derived xenografts subcutaneously, allow these tumors to grow, and then implant them in the pretibial space of mice. Once they've grown to about 1 to 1.5 centimeters, we amputate the limb, and we know at this point, having performed flow cytometry, that if we look at if we look at the lungs of these mice, we will see that we will be able to demonstrate disseminated tumor cells in the lungs. And so we can then allow the mouse to live with 3 limbs, and we can perform various assays. We first started by treating our mice with 1%, 2%, and 1% and 2% DFMO in the neoadjuvant setting up front. And we found that there was really no change whatsoever in the primary tumor growth, which wasn't surprising because if you recall, when I showed the spheroid formation, spheres that had already been formed were unable to be broken up, independent of how much drug we gave. However, when given DFMO in the adjuvant setting post-amputation, you can see on the right, almost all of the control mice had large local recurrences and metastatic lesions, and almost none had any disseminated metastatic lesions. The same is true for our Ewing sarcoma mice. We found that there was, again, the outcome was not changed based on which mice received DFMO and which didn't. So there was no death due to DFMO. But notably, our control mice, almost all of them had metastatic lesions, and our DFMO mice really didn't have many lesions. And the way that we quantify metastatic index is we give various numbers. So a 1 is for a small lesion, a 2 is for a medium-sized lesion, and a 3 is for a large lesion. And if a mouse has, say, 2 medium-sized lesions, they'll get an index of 4. Now you could notice on the right that there are 2 mice with DFMO did receive a metastatic index of 2. But I want to show you on the next slide what that really looked like. So you can see here in panel B, this is a mouse that was a control mouse, not treated with DFMO. This entire lymph node is enveloped with tumor. However, seen in panel C are these tiny little ditzel tumors in the kidneys. Now, we called these metastatic lesions, we gave this mouse a score of 2, but when we looked at this tumor microscopically, this tumor was quite inactive. So in panel D, you can see the IHC for this lymph node, and you can see active cancer cells. However, in panel F and G, when we stained for Ewing sarcoma cells, we were unable to do it successfully, and these mice had pure necrosis in all of these areas and did not have active cells. We then went on to utilize a preclinical model, utilizing chemotherapy in combination with DFMO. And we started by treating mice with ifosfamide at the time that we palpated a tumor. And not surprisingly, mice treated with ifosfamide up front had a delay in time to amputation because we always amputate at the same size. So that was not a surprise, as we know ifosfamide will often shrink a tumor. And we were able to demonstrate that adjuvant DFMO, giving DFMO after the tumor cells had disseminated, after the limb was amputated, prolonged recurrence-free survival of a p-value of less than 0.05. But most notably was that DFMO truly limited local and distant recurrence. You can see that there was a change between ifosfamide alone as compared to ifosfamide plus DFMO, but most notably, you can see that using a 2A ANOVA test, comparing a control DMSO to ifosfamide plus DFMO, p-value of 0.0005. So we then went on to perform RNA sequencing. And like I mentioned to you before, it's a little bit challenging to look at RNA sequencing of these metastatic lesions because if you treat them with DFMO, the lesions are quite tiny, if at all, and they're really completely inactive and necrotic. And so we opted to treat the primary tumors with and without DFMO and utilize those for RNA sequencing, performing single-cell RNA-seq. And we found that the proportion of osteoblasts increased with DFMO and the macrophages decreased. We then went on to look at various genomes, and we found that there was an increase in oxidative phosphorylation, MYC targets, not surprising in osteosarcoma, hypoxia, adipogenesis, glycolysis, and fatty acid metabolism. Again, not surprising because we believe that this is all due to urea cycle dysfunction. I'd like you to realize that there's also an increase in reactive oxygen species, which I'll speak about in a few moments. When we looked at the differential expression, we found that DFMO really enriches the translation, aerobic respiration, and oxidative phosphorylation, and there was a higher percentage of ribosomal genes. But like I said, DFMO did not look like it was killing the cells, but it was preventing metastasis. So we went on to look at various assays in vitro to try to understand this more. And we started by doing flow cytometry on our cells. We treated various osteosarcoma cell lines with and without DFMO and did a flow analysis to understand using live dead assays. And we saw that there was no change between the vehicle and the DFMO in numbers of cells that were dead. And to confirm this, we then went on to do CAS-based assays to demonstrate that we were not seeing any activity in CAS-based 3, utilizing chemotherapy, etoposide as our positive control, which you can see on the left panel. Even at various high levels of DFMO, there was no apoptosis whatsoever. And so again, we know that these cells are dying because we're not seeing metastasis anywhere, but it's not happening via apoptosis. But there are many types of programmed cell death. There's autophagy, there's anechoisis, and there's also something called ferroptosis. And there was a link found in a paper that came out in 2016 by Au et al. Linking polyamines and ferroptosis. And what they found is that SAT1 is the rate-limiting enzyme in the polyamine catabolism, and it's critically involved in the conversion of spermidine and spermine back to putrescine, those polyamines we spoke about earlier. What's ferroptosis? Well, it's a type of programmed cell death, and it's dependent on iron and characterized by the accumulation of lipid peroxides. Taking this all into account and realizing that our cells were clearly not dying of apoptosis, knowing that our mice were not metastasizing, we opted to look at this in vitro. We started by plating our cells and treating them with and without DFMO and extracting RNA and performing qualitative PCR. We found an increase in all of our cell lines at ALOX 15. However, if we treated those same cells with DFMO, in the presence of polyamines, we did not see any change in ALOX 15. We then performed pathway analyses on our single cells. Like I mentioned before, it was very difficult for us to use any types of cells that had any type of metastasis because we knew that these tumors did not metastasize. So instead, we opted to look for disseminated tumor cells. And we found that there was a downregulation of glutathione metabolism, which is a key inhibitor of ferroptosis, as well as enzymes involved in the pentose phosphate pathway. We then looked at analyses of the ferroptosis-related genes, and we found that there was downregulation of ACSL3, which favors the production of polyunsaturated fatty acids, and PTGS2, which is an executioner of ferroptosis. And so the disseminated cells displayed an increased vulnerability to ferroptosis compared to the primary tumor. And when we looked at these metabolomic comparisons, we found that these disseminated tumor cells had an increase in cysteine. They had a decrease in GSSH and cystathione, and they had unchanged in glutamate and cysteine. We then performed transcriptomic changes induced by DFMO, and we found that the pathway analysis was quite obvious. The control samples were very far removed from our DFMO samples and clustered well. We found an increase in cell cycle analysis, not surprising because, as I showed you before, we saw that there was a G0's G1 arrest. There was an increase in there was a decrease in apoptosis, not surprising because we knew this wasn't happening due to apoptosis. And there was an improvement in cholesterol biosynthesis, which again is not surprising because we know that ferroptosis will inhibit the polyunsaturated fatty acids. We then looked at ferroptosis genes that were induced by DFMO, and we found that HSPB1, which is a strong negative regulator of ferroptosis, is downregulated by DFMO. HMG-CR1, which is the rate-limiting step in cholesterol biosynthesis and a negative regulator of ferroptosis, is downregulated by DFMO. And LPCAT3, which is a driver of ferroptosis, is upregulated by DFMO. And so taking this all together, when you see a downregulation in ACLS3, an upregulation in LPCAT3 or ACLS4, a downregulation in HSPB1, HMGCR, and GST, this is where we believe ferroptosis is occurring. And so when Ewing sarcoma and osteosarcoma cells disseminate, they become sensitized to undergo ferroptosis due to changes in the expression of genes associated with lipid metabolism and glutathione metabolism. And DFMO, by depleting cells of polyamines, upregulate genes that drive production of polyunsaturated fatty acids and are the executioners of ferroptosis, mainly ELOX-15. An induction of ferroptosis in disseminated tumor cells is the mechanism by which DFMO prevents metastatic outgrowth of already disseminated tumor cells. And taking this all into effect, we thought, well, we have this wonderful model that we also use in our immunocompetent, and we have a P53 mouse when we cross with osteoid. It's an osteoid positive P53RB mouse. And these mice spontaneously develop osteosarcoma. We know this will happen at about 20 weeks or so. And so we opted to treat these mice with DFMO at 11 weeks prior to any spontaneous osteosarcoma. And we found an improvement in overall outcome and overall survival. And we found a decrease in tumor formation and a delay to presentation with a p-value of 0.009, demonstrating that, again, DFMO works to prevent the outgrowth of osteosarcoma. Taking this all together, our next steps are to perform a clinical trial with Beat Cancer Consortium to determine the event-free survival of patients with relapsed bone sarcomas who receive therapy with DFMO. We will have 2 cohorts of patients with osteosarcoma after an isolated pulmonary metastatic recurrence who are rendered disease-free by surgery. And we'll have patients who have metastatic recurrence of Ewing sarcoma who will be randomized to receive DFMO in combination with topotecan and cyclophosphamide. I'd like to thank my mentor, David Loeb, and all of our lab members, as well as our institution, the many wonderful foundations that have supported this work, and OsteoBites for inviting me to give this talk.
Thank you so much, Dr. Offenbacher. Super interesting, and thank you also for breaking that down and explaining kind of how that all works so well, and so exciting that this is kind of moving into clinical trial. So it's so interesting, I think, and it's so the whole difference about like how it doesn't cause apoptosis, but does prevent proliferation. And so if you can maybe go into some more specifics about kind of how that will inform your trial design, because I'm also curious too, because you showed some slides where the mice were treated with IFOS initially. And as you know, the standard of care for first-line chemo for osteo is MAP. So curious if you kind of looked at giving MAP prior and then following up with the DFMO after.
So great question. So we believe that a clinical trial is most needed for patients who have relapsed disease, which is why we chose ifosfamide, because ifosfamide is standard of care as your second-line therapy for patients who relapse, which is why we chose it. These mice also really have a hard time tolerating multi-agent chemotherapy, so it would be challenging to give them cisplatin dox and methotrexate. We have tried cisplatin alone, and they can tolerate that. But again, that's really not traditional care for a relapsed patient. Because we know that this drug does really not work at all on the primary tumor, we've designed the clinical trial in a way that ensures disease, no evidence of disease, meaning that you have to have surgery, radiation, or both, and your primary oncologist has to deem that you don't have positive margins, because we don't believe there would be a true benefit for patients who do have their tumor left behind.
And is there a optimal time? I don't know how it translates from mice to humans, but kind of an optimal time between that local control to when they should get on the DFMO?
So in mice, we actually start the day after. Our goal would be to start within 2 weeks, so give your body a chance to heal. But we know that DFMO is extremely well tolerated. We have appropriate dosages for children and young adults. And we have dosages that are compatible for patients who get cyclophosphamide and topotecan, because this has been a drug utilized in neuroblastoma. So it will allow us to start as a phase 2, which is wonderful. But we also know that we have to start quickly because, again, DFMO will prevent those disseminated tumor cells from forming a metastatic focus. But if we wait too long and a metastatic focus forms, the DFMO isn't going to work.
Right. And you talked about, so I think it's a pill, is that right? It's in a pill, which is kind of nice. And you talked about minimal side effects. Can you kind of address that a little bit more? What some of the adverse?
Yeah, so the main side effect we actually see is anemia, but the anemia is quite mild, and compared to the amount of anemia our patients classically see with chemotherapy, they don't even really necessitate blood transfusions. Nausea isn't really a factor. There's no issue with hair loss. And what's nice, and I didn't really have a chance to allude to this, is that we can utilize various models to ensure that a patient's metabolizing the DFMO. So in our clinically relevant mouse model, we actually collect urine samples to look for downstream effects of the DFMO to ensure that they're metabolizing it properly. And we're going to do the same thing in our patient population and ensure that the metabolism is working effectively in each of these patients. And we'll simultaneously collect circulating tumor cells and circulating tumor DNA, because we know that these are correlative and can be very beneficial for our patients.
Speaking
And
of side effects, you talked about dysregulating the urea cycle. Does that like have any effect on like a buildup of ammonia or anything? Or is that like, I guess, how does that work?
So we believe that the urea cycle is dysregulated in these patients due to the cancer itself. When we first started looking at this in Ewing sarcoma, we actually tried to compare. The urea cycle typically occurs in the liver. So we actually tried to compare healthy livers of mice not with cancer to the tumors themselves. It wasn't the best comparator because, again, we know that the tumor already causes dysregulation, and then you're giving a drug that's going to target that dysregulation. But it's very likened to a child who has a urea cycle defect, actually. Fortunately, we're very good at treating those now, but one of our collaborators is a geneticist, and she often says it's very challenging because the data that she would expect to have is no longer present because her patients are all being treated with ODC and OTC and various compounds that, correct the dysregulation of the urea cycle.
Okay, thank you. That makes sense.
and Dr. Offenbacher, so it's actually so great that there's already this trial in neuroblastoma, and I'm guessing that you're able to kind of model this trial design a lot on the NB trial. And so is there kind of set up the same way in terms of kind of how you're applying what you're learning from that trial to the bone cancer trials? Is it being used for like after relapse, for second line therapy?
So their initial trial was actually looking at maintenance after multimodal chemotherapy. And although I think that that's really a beneficial avenue for sarcoma research, I think that it's a little bit challenging for many reasons. One is there's an open osteosarcoma clinical trial with COG, and there will be one for Ewing sarcoma. But also, who would you opt to put on those trials? Is it going to be a patient who's higher risk? Well, what's going to be higher risk? Is going to be a patient has metastatic disease. What about necrosis? And there's all these different components. So we plan to have an exploratory arm for maintenance for patients, but I think that the real need is for patients who have metastatic disease. And that's why it's so critical. So we're able to pull some of the information and some of the techniques that they used in the neuroblastoma trials, but there's going to be a lot of like novel approaches to this, because I think there's a lot of challenges with treating local relapsed osteosarcoma in particular. And we know that chemotherapy, although it probably does kill the disseminated tumor cells, is not really doing a whole lot to the primary tumor.
Right. And what about, so there was something that you had mentioned that I thought was interesting and hadn't really kind of seen before, which is that I think the term was that it was like an irreversible inhibitor. So can you maybe talk a little bit what that means about it being a reversible inhibitor, and also does that pertain at all to resistance, and have you seen like developing drug resistance an issue?
Yeah, so the urea cycle is nice because it's a cycle. So if you have an increase in one of the processes or one of the enzymes, there's usually a feedback mechanism, in either direction. But once you get downstream towards ODC, ornithine decarboxylase, you're past the point of return. So there's no way for you to have any reversibility, because the only thing downstream are polyamines. And while that's beneficial in the sense that you know exactly what you're targeting and how to reverse that, if you can't reverse it because you have polyamine depletion, like in DFMO, for example, then you really face dire consequences. So I didn't show this data, but when we initially started looking at the urea cycle, we actually did a lot of different enzymatic expressions. And we were able to demonstrate that if you look at the classical urea cycle, just the 5 major enzymes that circulate, you actually see that if you treat DFMO, you treat the cells with DFMO, you see an increase in every single enzyme, because it's going to, if you kind of block one enzyme, the downstream one is going to have an upregulation, which is not a surprise, it's a cycle. But once you get to a point where it's no longer a cycle and you're downstream of that, kind of like towards the polyamines, you're stuck. So there's nowhere else for it to go. That's the last place.
And in your work, in your preclinical work to date, or maybe that's something also that you'll learn more for the trial, because this sounds something that's kind of like universally applicable to all patients, right? Like it's not necessarily dependent on having certain mutations or anything like that. And so, like, have you seen anything in your preclinical work about like who would best respond to this, or is it assuming that it would be kind of the same across patients?
So I truly believe patients who have higher risk disease but are rendered free of the disease would do the best. And I say that for a couple of reasons. One is we know that patients who have metastatic disease do worse. So we already are starting at such a low threshold of, outcomes. The outcomes are poor. But so we have a lot of room for growth. We also know that if you see a response to that therapy, meaning if let's say you have metastatic osteosarcoma, but you come out of it in remission and all of the nodules are removed and at the end of therapy you're clear of disease, those patients need it the most, but they're also in need of it the most, in the sense that, yes, their cancer is very intense. It's a very high risk because there's metastatic lesions, but they've also responded to therapy. So their bodies have allowed the therapy to work. So now we just need to keep them that way. And the way I think about it is often like a patient with leukemia. So, we spent a long time for many years frustrated by patients with leukemia because we would treat them, they would go into remission, and then they'd be stuck. It would come back and we didn't know what to do. And finally, we started with a year of maintenance. And that was really the tipping point. We were able to get them into remission. That wasn't the issue. It was keeping them into remission. And I think it's those same patients. We're actually pretty good at treating osteosarcoma. We just fail at keeping them in patients into remission. So we're good. At the end of therapy, we ring that bell. And then 6 months later, we turn around and we're like, oh, why did it come back? And I think that if we really utilize patients like that who we're worried about for a real reason, not just because we're worried about everybody, but we say, this patient's high risk because of X, Y, and Z, I think those are the patients we'll see the best outcomes.
So I guess would you like to see this drug used only in that standpoint, or do you think it would also be beneficial to go ahead and start that with like the regular MAP treatment as well?
Ultimately, I think it's going to be a drug that we use for every patient once they're clear of disease. I think it's going to be harder to put it into clinical trial up front for patients who receive standard MAP for a couple of reasons. One is a patient who has localized disease generally has a favorable outcome of almost 80%. So it's hard to do a clinical trial for those patients because even if I improve outcomes from 80 to 90, which it sounds like a lot, to enroll patients on a clinical trial like that, it would take years just to show an improvement. So it's harder to do an upfront clinical trial like that, but I do think that would come after we're able to demonstrate the beneficial need for patients with metastatic disease.
Yeah, I mean, there's so many things. I mean, there's so many advancements happening right now, but you can see it with all these things coming together, like better monitoring with circulating tumor DNA, and then also kind of with risk stratification. Because I think often too, the other, they're a little bit limited right now, I think, in kind of what the standard is for risk stratification. Like it is just, necrosis, for example, or presentation of metastatic disease at diagnosis. But I think people are working hard on like looking at other biomarkers for risk stratification. And then, but the question that always comes up, even though we can do that, we can define these biomarkers for risk stratification, is then like, well, then so what? Because then, like, do we have anything to treat the patients differently? So I think this helps. This is a nice like potential solution kind of on the back end. If we can get the risk stratification, get better definition around that, as well as better monitoring, so that we can catch that sooner, before it becomes, more visible or bulky disease. But it's nice then to kind of have all these things in play kind of simultaneously, and hopefully they'll all come together so that there's clinical benefit in the near future.
Yeah, and we often see improvements after the primary tumor is removed. And then we kind of have a challenge of like, well, what do you do when it goes up a little bit in adjuvant setting? And you're like, but I'm doing everything I know how to do. But if you see an improvement, maybe you should say, maybe this is a patient who could, utilize something like DFMO, because we know that it will work on those cells that have disseminated, even though they've already disseminated. We know that it works as long as you don't have a metastatic focus.
Mm-hmm. And so what is the timing for the trial, for the upcoming trial?
Our plan is to have it open by the end of 2024. So a couple more months.
Yeah, and will it be just at CHAM, or will it be at other locations?
So we're going to run it through the Beat Childhood Cancer Consortium. They have about 40 or 50 cooperating sites. So and then I actually was approached yesterday by another site that wants to join. I'm like, you should get on that now, because ultimately, there are sites throughout the US and abroad, but it's an oral drug, so patients can easily travel to an institution that has the open clinical trial, but it is nice to know that they're not traveling 2 or 3 hours to be enrolled in a clinical trial.
Right. That is a nice benefit, though, of the easy administration, because hopefully you only have to go in just for, and even like, I don't know if you're considering this for the trial design, but even like if some of the monitoring could even be done remotely, depending. But that's a lot of institutions to have in the consortium.
Yeah.
So there is a hospital near someone.
Yeah, there should be a hospital near someone, and we're really at this point planning to require visits pretty, frequently, like monthly, but the imaging and the specific testing you need to do is going to be every 3 months. So in theory, if they were seen in an outside institution for those other visits, just to make sure that they were, not anemic and otherwise feeling okay, then I think, that potentially could be possible.
Great. All right. Walker, any other questions?
I have one kind of about ferroptosis. So I guess what's the advantage of the drug causing ferroptosis, or is there, compared to apoptosis? Like, is that why it's more effective in preventing metastases?
That's a great question. I don't think that it makes it more effective. I think for us, what the challenge was is we saw that the cells were clearly not forming metastases, but we also saw that their cells weren't dying. And it kind of led us to this place of like, well, what is it? Clearly they're dying. And when we said there has to be another way of cell death. It's just not apoptosis. And when we ultimately looked into ferroptosis, this was about 8 or 10 months ago, we found that ferroptosis is described in sarcomas, not in the presence of DFMO, but in the presence of other agents. And what's really nice about it are there are ferroptosis inhibitors, so you can actually utilize those to even more compellingly prove that this is truly ferroptosis. And that was the last experiment I was talking about earlier that we just performed. But I don't think it's really more clinically relevant or more useful. I think it's just that it's another way that we understand that cells die. And what's unique to this is that, we knew that this drug worked for neuroblastoma, but no one ever knew why. And it's nice to use a drug that, prevents metastasis, but it's really nice to know that it works and why it's working. And if it stops working for some reason, then you can try to figure out if the mechanism has changed in that particular patient. So I think that's what makes it unique, having a mechanism and understanding it more.
Gotcha. That makes sense. Thank you.
All right, so we definitely have to stay in touch because we'd love to have you back once the trial opens, because it's always great to kind of give an overview of the trial design for any interested patients and clinicians. And also when you have a paper published on this, which sounds like hopefully will be soon. So we'll keep an eye out for that. But thank you so much. This was fantastic, and really enjoyed having you on. And thank you for making it better for pediatric sarcoma patients. More information on this and all OsteoBites can be found on our MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And next Thursday on April 11th, we will be joined by Dr. Kevin Campbell, who's a pediatric oncologist at Children's Mercy, Kansas City, and clinical assistant professor of pediatrics at the University of Missouri, Kansas City School of Medicine. And he will be joining us to discuss results from the phase 1 study assessing the safety and toxicity of cabozantinib in combination with topotecan and cyclophosphamide for relapsed osteosarcoma and Ewing sarcoma. You can find our OsteoBites lineup for the next few months on our website, and if you have any ideas for future topics that you'd like to hear about, please email us at events@mibagents.org. Thank you again, Dr. Offenbacher, for joining us today, and Walker also for spending an hour with us today. And thanks to all of you for joining us. We hope to see you next week on April 11th back here on OsteoBites when we chat with Dr. Kevin Campbell. Thanks, everyone.